In this video, we're going to cover a variety of skin pathology, and we'll start with autoimmune disorders that attack the skin. So autoimmune disorders that attack the skin. The first one I want to talk about is Pemphigus vulgaris. And pemphigus means blistering, and that's what you'll see. This is characterized by autoimmune attack, usually from IgG, against your desmosomes. What are your desmosomes again? Let's just recall. Your cell of your skin is connected both on the sides and on the bottom to the basement membrane. Yeah, and we talked about a lot of things. We talked about tight junctions. We talked about desmosomes. Desmosomes were those spot welds. And proteins that kind of connected were things like desmoglein. We'll add this to your list. This is IgG against desmoglein. They all have desmo in the name, so it's easier to remember. So this is going to be IgG against proteins in your desmosomes called desmoglein. It will affect all the desmoglein you have. So it'll affect this one, it'll affect this one, and this one, and this one. And it kind of encapsulates your cells. If you do an immunoflourescence looking for those antibodies, it'll look like it's a net. All right, net-like. Because you basically have antibodies here, and here, and here, and here, and here, and here. Kind of looks like a net around your cells. So, all right, net-like. And by attacking those connections, your cells can start to separate. Especially your cells of your stratum spinosum, so your spinosum can separate. What is our fancy word for talking about the stratum spinosum separating? If you say acantholysis, you are right. Acantholysis. And when it separates, it starts to form this bullae, this blister. That's where the pemphigus comes from, this blistering. And those blisters are found in your epidermis, and they're very fragile. Your skin is very fragile at this point. And, all right, fragile blisters. And those blisters can just pop. And your skin can just kind of scrape off because it's being separated. All right, fragile skin. You can actually touch the skin like this and the skin will basically come off. That is called Nikolsky sign. That's how fragile your skin is. It's basically being separated apart. One thing you should know, because the skin involvement and the blistering is so superficial, you can see it on your oral mucosa also. Oral mucosa. That has a ton of information. Is that how can we remember this? Well, let's just try and make it into a step-like question. And a patient comes in, has these blisters that break easy. When you touch the skin, you notice that the skin seems to come off. You look in the mouth, there's oral ulcers, and then they might ask, what's the mechanism? IgG against your desmoglein, against your desmosomes. Okay, or they might show you a picture of the immunoflourescence where you have IgGs just basically circled like a net around your cells, and then they might ask you something about, I don't know, what else could you find? Oral lesions. So that's just a way they can ask and synthesize all these variables into a question. Now there's a helpful memory aid that I like, and it's called DAM, is a vulgar word. So the vulgar meaning vulgaris, and then DAM meaning all the minute points that you need to know about Pemphigus vulgaris. So D stands for desmosomes, or desmoglein if you want. A stands for acantholysis. M stands for mouth or oral involvement, and then N stands for Nikolsky sign. And that's just an easy way to memorize all the minute details of Pemphigus vulgaris. There's another autoimmune skin condition that's similar, but not quite the same, and that is Bullous pemphigoid. Again, the pemphigoid is just a blistering, so you're going to form blisters again. And again, it's an IgG mediated attack against your own body. However, this time it's not your desmosome, so let me just kind of clear the air. This time it's against your hemidesmosomes. Hemidesmosome. What are your hemidesmosomes again? We just talked about it, so hopefully you remember. That's an attack against the things that link the cells to the bottom, especially your basement membrane. So it can link cells to the basement membrane, it can link the epidermis to the bottom dermis. So when you attack this, you just have antibodies all against the bottom of your cells. And it will show up on immunofluorescence. So instead of that net-like pattern, you're going to see this linear pattern. It's basically IgG on the bottom. All right, immunofluorescence shows linear pattern. And they like your basement membrane. They like a particular protein called basement protein 180 or BP180. So BP180. And just attacks it and can separate your epidermis from your dermis and form this blister in between. So I'll write sub-epidermal blister. So it's not as fragile as our friend here. Yeah, that blister won't just pop on its own. You can actually move the blister and it's kind of really stable. And you won't have Nikolsky sign either because again, the skin's not fragile, so you can rub the skin won't come off. So I'll write tense blister. And I'll write Nikolsky negative. It's a deeper involvement. And because it's deeper involvement, you also don't see oral involvement. So no oral involvement. Now, if you understand the mechanism of the fact that it's on the basement membrane, it's a little bit deeper, it's an easy way to separate them. You get tenser, harder blisters. You don't get Nikolsky sign. You don't get the superficial involvement. You just have this deep, tense blister. That is bullous pemphigoid. That is our first topic of today, aka autoimmune conditions that affect the skin. Let's talk about our next topic. Our next topic is going to be on skin manifestations of various diseases. A lot of diseases cause skin manifestation. We're not going to talk about all of them today because we'll be talking all day, but we're just going to talk about the important ones. So I'll just write skin manifestations of diseases. And I like to talk about this right after we talked about autoimmune disorders of the skin because this is kind of autoimmune related. A lot of times you have an infection or a drug reaction and it causes immune complexes to deposit in your skin. So it's kind of like these autoimmune conditions, okay? One of the first ones we're going to talk about today is pityriasis rosea. Pityriasis rosea. And it can be precipitated by skin infections. It can be precipitated by atopic reactions, drug reactions. And what you see on the body, so this is my patient, you'll see this large patch. And then following this patch, you'll start to see smaller patches that kind of branch off it in a Christmas tree-like distribution. The initial patch we can sometimes call a herald patch. Herald means messenger, like hark the herald. That initial patch is a messenger. You kind of know something's coming, and then those little small patches come in a Christmas tree-like distribution, so kind of on the side, kind of like a Christmas tree. There's not a clear mechanism of why this occurs. It might, again, just be some sort of autoimmune reaction, and then immune deposits deposit on your skin and causes Christmas tree-like appearance. Self-resolves, don't have to worry about it, just have to be able to recognize it. So initial herald patch, the small patches that come later. Next is erythema marginatum. They call it marginatum because it's this red mark that has this really distinct margin, like a circle. Seen in rheumatic fever. You should know by now. I don't really give a diddly dork if you know what erythema marginatum is. I care more that you know it's associated with rheumatic fever. So tell me everything you know about rheumatic fever. Pause the video, list everything you know. So hopefully you said it's from group A, beta hemolytic strep. Those bacteria that have a lot of protein, especially M protein, causes molecular mimicry where our body thinks that other proteins in our body is that M protein, so it attacks our own parts of the body. The heart, you can get pericarditis, you can get pancarditis, it can attack our joints, you get joint pain, it can attack our brain, you get chorea. So if you can list all those things off, just like that, then you're on the right track. Seen in rheumatic fever. Very important you know that. Next is erythema chronicum migrans. It's a migrating red mark. You see this bullseye lesion and it just grows. It like expands, it can grow really, really big. And it is pathognomonic for Lyme disease. Again, I care that you recognize what this rash is because it's pathognomonic, but I care more that you know is associated with Lyme disease. So tell me everything you know about Lyme disease. Pause the video, tell me everything you know about Lyme disease. If he says from ticks, Borrelia burgdorferi. If he says a spirochete, if he says you treat doxycycline, you're on the right track. If you said none of those things, then hopefully you can just know that's where you're lacking. You're lacking in microbiome, and then recap your microbiome, and then come back and watch these videos, okay? Next on the list, we're gonna have erythema multiforme. It's these kind of target-like lesions, almost similar to erythema chronica migricans, but that is huge and it expands. This is just these bullae-like lesions all over your body. Associated with a lot of things: HSV, Mycoplasma pneumoniae. What do you think I'm going to ask you? What do you know everything about? Tell me everything you know about this. Tell me everything you know about this. So Mycoplasma pneumoniae, you call it the one that lacks a cell wall. It doesn't really have peptinoglycan, and this little cell membrane is really cool. It's really fluid, and so it can kind of change its proteins and kind of mimic, and it can mimic ourselves so much that we attack ourselves, and that's why it's so associated with this kind of autoimmune skin manifestation and bullet lesions. Okay, so that's Mycoplasma pneumoniae. Tell me everything else you know about it. Okay, so pause the video, tell me everything you know about it. Move on. Dermatitis herpetiformis. Call it herpetiformis because it looks like herpes. It's not herpes. It looks like herpes, but it commonly affects your flexors. Now, what is this associated with? We did GIT before we did MSK. If you're from my alma mater, that's kind of the natural progression of things. We do GIT before MSK, so we would have talked about this by now. This is from celiacs. What do you think I'm going to ask? Everything about celiacs, that's absolutely right. We've been together long enough to expect a lot from you. I don't want you to say celiacs is blunting of the villi, it's associated with gliadin. That's not good enough. Tell me what HLA is associated with. Tell me to the point what antibodies is associated with. If you can't do that, then again, you have to review. You gotta work to that level. Okay, if you do that, step becomes really, really easy. That is dermatitis herpetiformis. Next is lichen planus. Lichen planus, again, no real clear mechanism. It can be from infections, can be from drugs, can be from some sort of atopic reaction. However, it's highly associated with hep C. That's probably the one that's the most clear-cut link. So, no, it's associated with hep C. And when you see the skin, you see all these lymphocytes that are attacking the epidermal, dermal layer. And what you'll see is these purple lesions. A great picture will be in my notes, so make sure you check that out. So these purple lesions, and they can be pruritic, and that can also involve your oral mucosa. So many autoimmune things seem to involve the oral mucosa. So this is another one that involves the oral mucosa. You see these white lines. These white lines. White lines called Wickham striae. Because it seems to be an autoimmune disorder. If it's really getting bad, then you can give steroids. Otherwise, it can self-resolve on its own. All right? Speaking of things that attack the epidermal-dermal junction, Steven Johnson. Steven Johnson is a horrible autoimmune reaction to a lot of things, particularly drugs. So you give a person a drug and they have an autoimmune reaction and their body just attacks and destroys their skin, their epidermal-dermal junction. So epidermal-dermal junction. Attacks it so bad that the two layers separate and your epidermis actually slough off. Your skin basically sheds. Your lips will shed, your skin will shed, the skin around your eyes will shed, everything will just shed off you. It's a horrible disease. I have some pictures. Make sure you didn't eat lunch beforehand because they're pretty gnarly. So I'll just write shed mucosa. That's not a good sign. So shed mucosa. If it involves less than 10% of your overall body surface, then we call it Steven Johnson. If it involves over 30, then we're in real trouble. We call that a different name. We call that TEN, or toxic epidermal necrolysis. Toxic meaning toxic, epidermal because your epidermis is coming off, necro meaning dying, lysis because it's separating. So toxic epidermal necrolysis. That is our second topic of the day. Skin manifestations of other diseases. Now, our final topic of the day is going to be skin manifestation of Malignancies. So in particular, we're going to talk about skin manifestations of malignancies. The big one is acantholysis nigricans. What does acantholysis mean again? It means epidermal thickening, especially your spinosum. So you get this thickened epidermis, and it's hyperpigmentation. And it looks like this velvety dark layers. It usually affects the creases of the skin. So your neck, your flexors, you'll see this dark creases. Very, very, very common. And you might say it's not associated with internal malignancy. It's associated with things like metabolic syndrome. It's associated with things like type 2 diabetes. And you'd be absolutely right. Metabolic and type 2 diabetes. Commonly in type 2 diabetes, you have actually increased insulin because you have insulin resistance, and they think that insulin or insulin growth factors can cause this hyperplasia and this epidermal thickening. And it is more commonly associated with this, but if you see in a patient that doesn't have these classical signs of metabolic syndrome and type 2 diabetes, then you're thinking that there might be some underlying cancer, especially GIT cancer. Okay? So they're associated with both. Don't get caught up on one and forget the other. They're associated with both. Next, since we're talking about these dark pigmented lesions, let's talk about seborrheic keratosis. You have increased keratosis. You have seborrheic, which means increased sebum. So you have this really thick, greasy, enlarged lesion. Looks dark. It's all right. Greasy, dark lesion. Filled with keratin. If you do a histo, you'll see all these keratin cyst-like lesions. But grossly, they look like these black waxy lesions that are stuck on. Like if you chewed black gum stuck on a person, it would look like that. Very common in older people. A lot of older people just have it. You'll see it commonly. But if it just crops up overnight, all over your body, that's not normal. We call that the Lesser-Charlotte sign. And again, it's associated with malignancy, commonly GIT malignancy. Lesser-Charlotte sign. So these are easy to remember. They're both dark lesions. They're both associated with internal malignancies, most commonly GIT malignancies. Now I want to transition this talk about malignancy into skin cancer. So one of the things I want to talk about is something called actinic keratosis. Actinic keratosis is just a pre-cancer of your skin. You get keratinocyte hyperplasia and dysplasia, usually because you get sun exposure, and that UV light causes hyperplasia, causes dysplasia. And if you leave hyperplasia and dysplasia lasting too long, then you can get increased cancer, especially squamous cell carcinoma of the skin. We're going to talk about skin cancer soon, but I just want to use this as a nice segue. Because you have all this increased keratinocytes, increased keratin, you see these scaly, flaky lesions. Scaly, flaky lesions. The more scaly, the more flaky, the more extensive it is, the higher the risk. You can treat it. You can stop that cell proliferation by giving chemo drugs like 5-FU. And that kind of prevents it from going any further, okay? So that's just a nice segue into our next talk, which is skin cancer. Hope you enjoyed this video. Thanks.